Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Nate, and he's going to go over his talk on training gaps that he was supposed to present at SOMA, but somebody else was running their suck. Nate, I'm going to let you do a quick intro, and then you can just jump into it, okay?
Hey, Dennis. Thanks for having me today. So my name's Nate. I'm an 18 Delta from First Group. Spent all of my time there. They're at Lewis, Maine, or at SWIC. Currently, I'm the NCOIC of the Special Forces Medical Sergeant Skill Sustainment course for about 3 years at Fort Bragg. And I was asked to do a presentation at SOMA this year, but I got bumped for a couple of reasons. So this is pretty much my brief that I was going to give there that I never got to give. So the topic of my brief was medical training gaps, specifically inside of 18 Deltas and what we do day to day. And again, I've been an 18 Delta for a pretty long time, so I know both sides of the story about what we do every day on a team and what we can do and what our issues are with training. So one of the training gaps I see from working here for the past 3 years is just how we train. We don't do enough medical training. We do a lot of other training. To kind of bring this back, last week I did a training event here at SWIC, and I had a bunch of non-medics go through 2 days of training. And one of the things I talked to them about is, even outside of combat, there's probably going to be a time where non-medics or medics need to do a level of medicine that maybe they're trained for, maybe they're not trained for, or maybe they have no practice, but they're just expected to do stuff. There's probably a chance that everybody will have to do medicine before I have to emergency fill a radio or, clear a building for a high value target in North Carolina, or get into a gunfight where I need to be super spun up on a weapon. But car accidents, just events in day-to-day life, you'll probably see medicine in everything we do before we actually have any of these high-risk events that everybody trains for. I know I probably did a lot more door charges than I did tourniquet training when I was on a team. So bringing it back to what we're talking about right now, the level of training we do, and I talked to a lot of people, and I gave this brief probably 3 or 4 times already outside of SOMA. And it's always the same things I ask guys. We train for MASCAL a lot. I feel like MASCAL is the thing we do the most training in, if that makes sense, because for most of us 18 Deltas, we go through Robin Sage, and there's going to be a MASCAL event. You're going to have a bunch of patients, and they all have to fit super neat into a category, and you're going to have to do medicine. And one of the things I've seen guys do it across the board here is most time we have a MASCAL, it's 4, 6 patients, maybe 8, but they all fit into a nice, neat little category. Like, oh, I have 2 patients that are, each in this category, and these guys are expectant, and these guys are urgent, and these 2 are delayed, and these 2 are the ones I have to treat, and these other 6 somebody else can treat or not treat depending on what category they're in. And I just need to make it an hour and a half or 2 hours, and then my resources will run out and I won't have to do any more medicine. And it's never training for, if I have a MASCAL and I don't have enough resources and I don't have people and all 6 of them are in this category and all of them need blood and all of them need all the resources I have, and it's going to last 7 hours. I've never trained for that. Most people I talk to have never trained for that. Most people who come back and do lessons learned say oh, we've never even talked about this. And I had this thing happen to me where I had a casualty and it lasted for 3 hours, and then I thought I was done, and then all of a sudden I got 4 more casualties. Oh, then I thought that was done, and then I got 20 more casualties. And so my mass cal event was 2 hours into it, but with all the patients I had, it lasted 10, 12 hours, and I've never trained for it. I never practiced for it. I never had any support. The other thing we do, I think poorly when it comes to training, is triage. We trained to follow an algorithm. Whatever that algorithm is, whoever invented it, whoever came up with it, is, going back to the mass cal, we have four cool little groups, and we always have people that, fit into each one, and we try to do the thing, to make the event, to do the training, but we never really talk about what makes a person fall into those triage categories. We never do it in a situation where multiple casualties over multiple distances with time trying to get back to one location, or does it make more sense to move a medic from one event to the next event with support? What happens if you're triaging and all the patients or casualties are fitting into the same triage category? We always have these cards, these cool little kits that have colors on them, or numbers, or chem lights, and we talk to people, and when we do the training, it's like, well, why'd you put that guy in that category? He was bleeding, so he got a tourniquet on, and lifelong MRI site. Well, that's not really what's going on with that casualty. Just because you have a tourniquet on does not mean that patient's not stable. Going from, hey, let's make it 2 or 3 categories of like expectant, stable, unstable. Like, what makes this patient stable? What makes this patient unstable? It's not something we ever practice. We do a lot of stuff, where there's a choke point, and your team sergeant's there, and he's controlling the choke point, and he's talking to your alpha, and you can see everything. Everybody can see you. But what happens if it's inside of a building and an IED goes off, and you have 6 casualties, and 5 of them are really, really bad, and one's not so bad, but you can't leave to make sure that the litters are getting brought to the right place. So you tell your team sergeant, hey, I need all these people taken to the HLZ. The bird's going to be here. You can hear them on the radio. This one needs to be loaded in first. These 5 go in last. And, you have every intention of going with them. And then all of a sudden you take more casualties. And now your team sergeant's trying to control the CCP. He's trying to get litters moved. He's trying to get people put on a helicopter. Now there's a distance. These litters have to be carried, handed off to the alpha. They get onto the helicopter. Who knows what type of order they're put into. So we never train for realistic training or things that could happen. We always train for an algorithm or a time. One of the other things I see that's huge is our lack of prolonged casualty care. We have guys come, it's the hot topic. Everybody wants to do it. Everybody wants, PFC training, or PCC training, I guess now. And when do we start that? Like, in what phase do I go from casualty care, or, even into transport, CASEVAC? When do I officially start prolonged casualty care? What resources do I have? How many patients? It's never, we don't do well enough looking at our lessons learned, and to say, I'll use the Philippines for an example of one of the lessons learned I had. This medic was getting patients 3 to 4 hours after they're injured, but we never really talk about if the patient made it to you 3 to 4 hours after injury and they're stable. We just use time as triage. How much resources do they need from me? What are the things that I have to do for them? Am I already in prolonged field care? Am I already doing stuff that's going to make a better outcome for that patient further down the road? One of the other things that I see, and I know there's a lot of things that I see, but I've been here for a couple of years and I've just noticed the same things over and over, is training inside the units or inside even the schoolhouse. AAR is not being realistic. An example of that would be, I have a student. He's here. He's on his 3rd day of class. It's his day to run his trauma lane, and he just absolutely does terrible, and doesn't ID that the patient doesn't have a radial pulse, that patient needs blood, that the patient makes all of the mistakes. His aid bag wasn't packed properly. He didn't know where things were. He's dumping all his stuff out. He's panicking. He can't make it there. When we go to the AAR, and there's no honesty in the AAR. No one's saying stuff like, "Hey man, like your aid bag was garbage. You did not have it packed the right way. You don't know where your own equipment is. You don't know what drugs you're carrying. You don't know how to carry those drugs or administer those drugs." Instead, you get stuff like, "Well, I thought when you walked, you had a lot of confidence, and like your left foot went, and then your right foot went, and then your left foot. So like you looked pretty good walking up to the scene. You just said BSI, scene say, and then the second guy just says like, oh, I think the first guy pretty much covered everything. Like I don't really have anything to add." Like that doesn't help make a better medic. That doesn't help guys understand what they're doing right or wrong. It just makes them feel good about failing at their job as being a medic and keep people alive. MPT refreshers, it's one of the things, and especially for the 18 Delta community, for the guys that are doing this job. I know guys don't get the schools they want because they had to go to refresher, or they had to go to MPT, or they had to go to, the surgical refresher, or anything they do that's medicine. Well, that you got a school this year. You got to go to one of the quote unquote refreshers. So you got your training, you're good. And we treat people like that even at the units. Like, oh, you just went to the refresher, you're good for 2 years. You don't have to do any extra medical training because you also have to go to MPT, and you also have non-trauma modules to do, and it's all tied to your pay. So you just check the blocks that you have to check to make sure you can get back to your team faster and do the things with your team. And nothing extra is ever given to you training-wise. Cross training is another one, and I'm super guilty of this one. Being at first group, I had Rangers and 160th just down the road. I could run to their compound if I wanted to. And being there for as long as I did, I never once went over there and talked to the 160th medics or talked to the Ranger medics and said, "Hey, can we do some cross training? Can we train with you guys? You come train with us? Hey, can I go look at the platform that may have to take one of my casualties so I have a better understanding of it? Hey, FST, can I come work with you guys for a little bit? Come to the hospital, see what you guys do? Can I look at this fixed wing medevac platform?" It just, none of that stuff ever happens. We don't cross train. We just think that like, hey, we're the best. We've gone through the most training. We're definitely the top of the medical food chain when it comes to soft medics, and we never take the time to figure out what everybody else is doing. There's a lot of good things that other units are doing that we adopt years later, but if we had the foresight to go do cross training, we might have picked those things up sooner and see what other people are doing and could make us a better medic. We don't do enough training medically at any point, at any day. There's units out there that they put medical training into every training event they do. So if they're doing a static line jump, there'll be a casualty there. If they're doing a flat range, there'll be a casualty there. Moulage training, the patient has a role to play, it gets briefed up about this is what's wrong with you. If they do a ruck march, there's going to be a casualty there. If they do PT, there'll probably be a casualty there. Every event they have, they put a casualty in there. So, the medic can get more training and more hands-on working with his guys, or the medic can take a step back and assess his guys. Are you confident in March and TCCC? Can you do these things? And it shouldn't take 2, 3, 4 hours to do this. If you're just at a flat range, zeroing or shooting targets, what's the harm in just having a casualty moulage and put into the scenario, oh, the alpha just went down, or the team sergeant, or one of the medics just went down. You guys need to treat him and get your hands on. Or why doesn't the unit provide more training? So I've talked to lots and lots and lots of medics, and some units are really good at this. Their battalion sets up training, or their group sets up training outside of non-trauma modules. It ensures there is training events for the medics to take part of. It wouldn't be a super hard thing for a battalion medic to set up training and, talk to the medic and say, hey, next time you guys go to this whatever training event you're in, we'll show up, we'll put a bunch of casualties down and do the moulage for you and ensure that the medics are getting some extra training. Having said that, we work with and for providers at the unit who do a ton of sick call, but rarely take part in any medical training. They don't come and watch their medics. They don't see what their medics are capable of. I think one of the great things that we're kind of moving towards is having providers at the group, at the battalion level, come through one of the 2 skill sustainment courses to actually see. And the ones I've seen come through, it's an eye-opener to them. Like, oh, wow, I didn't know this is what the course was about. I didn't know that this is what is expected of my medics. Like, I was unsure about this. Now I'm confident my medic can do this. But it's incredible that some providers stay there for 2 to 3 years and never have an interaction with any of their medics that's actual medical training. It's just, oh, I have a guy that needs the shot, or it's sick call. And, a lot of other units put a lot of time and effort into training their medics and keeping them trained and taking responsibility. And I see that across the board, especially in the 18 Delta, in the SF community, that it's not part of everybody's mindset, even though we do a lot of other extra stuff that doesn't really have anything to do with our jobs. We provide the most support to the team, but we don't get that same support back to become the best medics we can be. Your name's a blue name on a con-op. We expect you to do this. You don't need anything from us. I'll kind of go into, why I started thinking about all of this stuff and, what happened to me. So again, I'm guilty of most of these things, and it's not a hard talk like, oh, you all are wrong and you guys shouldn't be doing this. There's things that I've seen and things that I've done that, I've made the mistake. So learn from my mistakes and make yourself better. So this is going to be about a location in 2018. I don't know if I'm allowed to say the name or not, probably. Ghazni City, 2018. It's a 72-hour. The mission was 10 days long, but this was about the first 72 hours of it. We had 2 18 Deltas and 2 PJs and a 68 whiskey was our complete medical package. That included 2 ODAs and a B team and 30-ish uplift soldiers, plus about 120 partner force that we were with going down into Ghazni City. So not a very robust medical package. We had five medics plus a bunch of aid bags. I think a total of 6 units of blood that we were carrying with us. Vehicles, so we had extra equipment on the vehicles and litters. The first ambush we got into was the first night we were driving down there. And we took a couple wounded, nothing that wasn't outside of the normal RPG blast off. A lot of it wasn't life threatening. It was just like, hey, can you keep going? Yeah, you have some penetrating trauma. You have, some shrapnel in your shoulder or some shrapnel in your leg, or, stuff that we could fix later. They didn't need to be medevaced. A couple guys had pretty severe concussions, didn't do well on their MACE exams, but it wasn't a position where we could just stop and put out colored cards and have a CCP. We had to continue moving, so it became the medics moving between trucks when we'd come to a stop and just open the door and be like, hey, everybody in here good? Like, what do you got? All right, let me fix this real quick. You sure you're good? Move on to the next one. We end up having to medevac one American who took frag to his eyes, and even when we were medevacing him, there wasn't a lot of communication between the medics. It was like, hey, we got to medevac this guy. Okay, I'll move to your location. Here's the HLZ. They came and picked him up and left. Almost immediately after that, we had a second ambush where we took seven wounded. Our CCP was non-existent. Our triage was non-existent. It is nothing that we could actually, looking back on it, was nothing that was actually set up. We took all of the wounded and we brought them back to a single location. We opened up our mass cal bag, which was just pretty much a truck bag with extra stuff in it to get through March. And we started treating. All of them were urgent surgical. All of them had penetrating trauma to the box, amputated arms or legs, penetrating trauma to the head, multiple crikes, finger thors. We hung some blood on the guys that we thought we had a good enough chance. Packing, wounds, stabilizing pelvises, getting them on litters. We ended up putting all of them on dust off, and dust off took them back. But there was no, like, okay, these two here, these three, they were all bad. They all fit into one category. We didn't have time or space to set up a CCP. We didn't really have the ability to do triage because it was a massive explosion. So everybody is bad. Like, we don't need to go through all those steps. What made it difficult was there was no help outside of the 218 Deltas and the 2 PJs. The rest of the team was kind of doing a Mexican standoff. They thought that the Americans had just dropped a bomb on friendly forces. We were trying to convince them, like, hey, friendly forces don't shoot at helicopters with RPGs in the middle of the day. We're the only ones that have helicopters. They don't drop mortar rounds on American vehicles in the middle of the day. It's probably more likely these are bad guys wearing good guy uniforms. And so the rest of my team was pulling security, was trying to talk down the local nationals from trying to shoot us. They were trying to run medical equipment to us. It was 6 casualties, 3 medics, and we're just doing it. All the casualties are lined up side by side on litters, and we were just doing a rotation. Like, I'd treat 2, and Gavin and Paul would treat 2, and then we would kind of switch to get new eyes on the patient and communicate the best way we can. Like, hey, I did this, and this. Like, hey, this guy's unconscious because I pushed this drug. Quickly after that, we cleaned up, and we were probably another 2 hours down the road, and our partner force got hit by an IED. It was built into the road, and we had a truck of 4, and all 4 were wounded. And it was, again, like no formal triage, no formal CCP. It was just, hey, we have to treat these guys. We have to continue. We're in a very bad place right now. Like, get them back to vehicles, put them on vehicles, and another partner force vehicle will take the lead. We get down to where we're finally going to be setting up for the night, and we get a call that we have 25 local nationals that are coming in. They're wounded. We have no information besides that. We don't know if it's 25, if it's 30, if it's 5. We don't know how they got wounded. We don't know the severity of their injuries or when they got wounded. We just were told 25. So we start setting up a formal CCP. We find a building. We have a door coming in. We bring a bunch of medical equipment in. We have bags set up. We start figuring out, okay, this is the room. This is the categories. We'll put all the medical stuff in the middle. As they come in, we'll have one medic triage and say, like, hey, if they're really bad, they go here. If they're not so bad, they come here. We kind of took away all the different categories. Like, hey, this person needs to see a medic now to stay alive. This person can probably wait. So kind of a stable, unstable kind of setup. As we're walking out of that building, it takes a rocket, and everybody inside the building was wounded, and it turned into another mass cal event. But again, like, no support from anybody around, because the teams, there's 2 ODAs on there, are now in a firefight. They are manning vehicles. They're going to the walls. They are trying to repel the attack. They're trying to give us information. We're trying to get air assets in. Like, medicine became a non thing for them because they were trying to keep the medics alive so we could do our jobs as medics. And we were trying to, fight through it, but it became one of those things like, oh, fight, the best medicine is to make sure there's no more bullets flying. Well, if you're getting attacked by a larger force and you've already have casualties, you can't really stand up and walk away from them to go man the walls, if you will. So 6 more. Again, we thought we had a triage. We thought we had a CCP, and the rocket hit, and it destroyed most of our medical equipment. It absolutely just decimated these 6 members of our team. My team sergeant was doing the best he could to control the CCP. Again, no fault of his own. We were sending litter bearers and patients to the HLZ that I didn't have eyes on, the team sergeant didn't have eyes on. He's trying to, coordinate security and help. The team leader is trying to coordinate drops and air support, and the HLZ. Everybody was like gainfully employed. We didn't have enough people be doing the things we were doing right now. And then what happened was all of the local national litter bearers who were carrying all of the litters ended up staying on the helicopter, and we ended up sending 36 people back to the role 3. So like the training we did on CCPs, it was always very controlled. Like, here's your area, here are the 4 categories, here's all the help you need. It will always be this help. Look, we're gonna move towards this area, and we're gonna reverse load all the casualties, so the worst ones coming off first, and great triage. You knew exactly what was going on, and that's great, but it's not realistic. Most guys I talk to have never done a mass gal in that event. It was here's a bunch of casualties, start doing work, and quickly we get into the point where we're like, okay, tourniquets need to go on. Okay, what's the next thing? And you kind of get tunnel vision and brought into this area. Like, I have to do medicine. I can't walk away. I can't take a step back. I have to treat all these patients. Later on that night, we had to go into the city center. We took a couple of RPGs, 4 more wounded. This one was not, again, it wasn't that big of a deal. Like, yes, we had a wounded, but they weren't all critical. They weren't urgent surgical. So we were able to keep them alive, bandage them up, and get them pushed over to another unit and our sister ODA, and they were able to take them to the HLZ and get them all medevaced. Some of them were penetrating trauma because of blast. Some of them were just TBIs. Some of the guys were just so messed up that they couldn't actually function in their jobs. Stuttering when they never stuttered before. One of them didn't pass a MACE exam for 30 days after medevac. It was just, didn't have to be, blood. It was more of, they had bad TBIs. So we're kind of on like day 2 at this point, going into day 3. The city is on fire. Every government building in the city was taken over and set on fire. There's not a lot of people in the city. I would say everybody in the city at the time is bad. They're trying to hurt or destroy us, and we are definitely getting pushed around a little bit. We have air support, but we're getting these little quick ambushes from all these weird areas. And the local nationals who were in the city for the first 3 or 4 days of fighting are like, oh, okay, the Americans are here. Let's go talk to their medics or doctors or whatever they thought we were. And so we started taking in 20 to 30 patients at a time. And it was no longer let's triage. It was, who are all these people showing up? Now we have to, point guns at them to make them to stop, and they just want help. And now we're searching them for grenades or suicide vest, and the triage became like, okay, first person, pat them down, look on everything. If we saw anything that was super wrong with them, then that was kind of our plan. We were treat those things and get them inside. Well, then it was brought to our attention that, like, hey, why are the medics going outside the wire or outside our little HESCO area? Like, why aren't the local nationals doing it themselves? So then we started trusting the local nationals, which I've never done any medical training with any of them except for the medics that were assigned to that unit, to go out there and try to ID what massive hemorrhaging looks like while they're patting down looking for guns and weapons and explosives, or to communicate to me through an interpreter that this person's not breathing. And some of them were just really, really bad injury patterns that there's really nothing we can do, but we can't turn them away. There's no hospital to go to. It's us. So we would get 3 or 4 in. We would try to triage them, get them into their little groups. A medic would take kind of each group, and if he needed help, would get, ask for help, and we'd get some more support to them. And it was just 20, 30 patients. Okay, then 4 more. Okay, 5 more. And we started getting patients that weren't even hurt in the current conflict. We had one patient come in who was limping and had blood, and I, tried to talk to him, and I was like, okay, what happened? And they're like, oh, RPG. I was like, okay, like, where did it hit you? And he's pointing to his legs and his abdomen, and I'm looking for blood. And I'm like, okay, take your shirt off. Like, let me see what happened. And he's like, yeah. He says that he was hit by an RPG. And I was like, okay, when? And they're like, 18 months ago. But he has an appointment that he has to get up to in Bagram. And so he just needs a helicopter ride there. And I'm like, now is not the time to be coming. They just wanted out of the city so badly. It was just, oh, I have to go get more medicine, or I have to get out of here because I have an appointment because I was hit already. And you don't train for this. You don't train for, there's never been that I know of a training event where you get 40 people coming through your facility, coming through your checkpoint, trying to get triaged. It's just something we don't do well at. We don't train well enough for any of this stuff, or just trying to think of like, hey, what if you don't have enough medical equipment? Kind of going back on that is a lot of the training we do is go ahead and pack your aid bag, get your gear perfectly. Now here's a casualty. Oh, great job. Like, go repack your bag. And it's less of, here's a patient. Here's your aid bag that you packed. Okay, this patient just left. Now here's another patient with the same aid bag that's not repacked. Go ahead and treat that patient. Okay, that patient's left. Now here's 2 more patients with that same exact aid bag you're running it. That's more realistic and stuff that medics are seeing, or we're seeing, when they're going into these cities and taking casualties after casualties, and not necessarily Americans, but still local nationals or partner forces, where you're out of equipment. We never train for that. We always try to make it best case scenario. Like, it's something that you'll be able to save and you'll be able to take care of with the stuff that's in your bag, which is not necessarily true. But I guess I digress. Later on that night, later on that afternoon, we got into an ambush, and this is where my PJ, Gavin, ends up getting hit, and they take an RPG to the open hatch of their RG-33. He's hurt. At the time, I didn't know that one of the other guys in the back was hurt. When I first got to him, I thought it was Gavin's blood on him. Ended up being his own blood. I kind of feel horrible. I did 0 triage. I just looked at him. I'm like, are you good? And he's like, yeah, I'm good. I'm like, get out of the vehicle then. And he was trying to tell me that, like, no, he's also blown up. But I was like, you're fine, man. Like, you're talking. Get out. And later, I apologized. I found him, and I was like, hey, man, like, I didn't know. Like, I asked you if you were good. You said, yeah, I'm good. I thought blood was from him, not from you. I feel super bad. He's like, no, it's fine. The other medic grabbed me as soon as I got out of the vehicle and took care of me. And I was like, I still feel terrible about it. But we don't do, good enough training, I don't feel, on being a casualty. It's like everybody just assumes, and I've heard this before, and it's, I've had to argue with guys, or they're like, it's okay. Like, we're going to go into this super shitty situation. Like, we have a medic with us. Like, that shouldn't be the mindset. Like, it shouldn't be like, oh, we have a medic. It should be like, hey, we're well enough trained as an individual, as a group, that if the medic gets hit, that we can treat them. Or being a casualty on your own, just, if the medic moulaged himself and introduced himself into a scenario and let everybody treat him, he could sit there and watch them literally treat himself or treat him and see exactly what they're doing wrong. Okay, well, like, you're not great on IVs, or you're not good on this, or you didn't ID this, and give an honest assessment of what training events he needs to set up for his team so they can keep him alive, and if the worst has happened. Gavin was a terrible, terrible patient. And it's not because he is a bad person. It was because he was just as well trained as I was. So he was thinking 2 steps ahead of me, because he wasn't going through the process of like, okay, he needs a chest seal here. Okay, I need to do this here. He was like, he wasn't actually prepping the equipment. So while I was prepping the equipment, he was thinking what was going to happen next, and would try to talk me out of doing certain procedures. Like, he didn't want a needle D, he didn't want a finger Thor, he didn't want a chest tube, he didn't want anything, because he just didn't want IO. So, excuse me, he didn't want any of that stuff. So what he did instead was, be like, hey man, like I'll just do it. I'm fine. Like I can breathe fine. Like here, listen to me breathe, and like, make up some bullshit like breathing rates, or like look how clear I'm like, no, you have like literally have trauma, penetrating trauma to your chest. Like, oh, I just need a chest seal. I thought that was funny. Him and I were kind of laughing about it as we're, that day, and other times we've talked about it. But it kind of made me think, like, man, like I've never actually been a casualty for my team. Like I've watched my team do training. I've done training with them, but this would be a great time where like the battalion or the group medical sections step in and say, hey, we're about to do this training. The medics are the casualties. You have to keep your medics alive. Medics, here's your brief, very detailed. These are the things that are wrong with you. This is what we're expecting for you to do. If they do this, this, and this, you get better. If they don't do this and this, you get worse. Here's your time limits. Here's their critical criteria, the things they have to do to pass. Here are all the things that they get, and you just prepared. We try to do that here is, give all this information to the person who's a casualty, so they can kind of play along in the game and make pretend land of like, yep, I know what's wrong with me, so I'll act accordingly. So when they do an assessment, it's not like, oh no, it hurts so bad. They're actually giving real feedback to the training. I can keep going, but there's an ambush that night, 4 casualties. Partner forces tried to go out and do a counter mission. They took 25, and then they tried to do the same thing the next night, took 15. So pretty much by the time I got to Gavin and everything was going on, I was out of medical equipment across the board. I mean, we were using what we had in IFACs to do initial treatments. It's another thing that I think we have training gaps, and we always have the best and greatest equipment to do all this stuff. And, it's stuff that it's time savers, it's lifesavers, it's definitely things that we can use. But what happens when all that stuff runs out? What happens when your pre-made crate kits are gone? What happens when you don't have any chest tubes? What happens if you have no more blood? What happens if you don't have drip sets, you only have Y tubing, but you're trying to give drugs through normal, a bag of normal saline 250, and I don't have drip sets. So I don't know how fast that stuff's actually dripping in through that filter, because I don't have any more drip sets. I only have Y tubing. What happens if I run out of drugs? Like this, I ran out of drugs pretty quickly. I didn't carry very much with me. We were only given limited amount, and I was using it just as fast as I was getting it. So when Gavin got hit, like I used what I had, and pretty much before I got in the helicopter, he was like, hey, this is what I have left. You should take it with you. And I was like, yeah, you're probably not going to need any more. You're gonna get a ticket out of here. So I ended up using a bunch of his stuff. I was sharing with other medics. Like I would talk to Paul and be like, hey, I'm low on this, 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 and this. What are you low on? He's like, I'm on this. Like, can I trade you 3 for 3, or I'll give you 1 if you can give me 2. And we were cross-loading our bags. Like our towards the end, what I had was like a slightly packed aid bag on my back, a March bag, and that was about it. Like no extra equipment. Even the equipment they were sending when, on the 5th or 6th day, they sent a sling load bird came in carrying a bunch of equipment, and it was all stuff like I didn't really care about. It was amazing how many times I got stuff I didn't ask for because they wanted to fill the kicker box, I guess, to make sure it was going to fly the right way. But it was like, oh, you didn't ask for 10 cases of normal saline in 100 ml bags. Like, nope, didn't ask for that. Like, oh, we're pretty sure you asked for a bunch of condoms. I'm like, nope, not now. We're in combat zone. Like, I don't need to transport water right now. And so it was just, they were giving us stuff that like literally couldn't do anything with. So I guess we'll keep moving ahead. One of the other things that we kind of have a failure in training with is how we actually treat our patients. We learned a certain way, an algorithm, if you will, in the schoolhouse. I think all schoolhouses do it, not just ours. But we never learn a different way outside of that specific thing. I learned how to do a delayed primary closure when I was in the course, and never thought there was a different way until I started to work with other units and their surgical assets and FSTs. And I thought I had a really good idea of like how everything should be set up. And it was like, nope, just spray it with some betadine, clean it out real well, look for these couple things, and then get them on to the next thing. Like, it was far from sterile, some of these procedures. It was like, hey, we're in the dirt, we have to do this now, and this is how we're going to do it. Or, hey, like we've done the best we can with this level of training or this level of medicine. Like, they have to get to the next level, and they have to, like, so you need to take that tourniquet down. Like, okay, well, I've trained on this, but, you know, the way you just did it is completely different than I've ever seen. So not a lot of outside the box medicine. I definitely don't do that. I know I'm asking for a lot. I'm asking for, you know, medics to do more training and their team to support it, and battalion and groups to support it, and support more cross training. But if you also get the time after doing the like super important information awareness training, or making sure you get a 1+1+ on your language, or, you know, doing all the train ups for JSATs, like if you could you also go to other units and cross train with them, like FSTs and in the MAU. Kind of IDing what is good enough and like what has to happen. So if something works and it's good enough and we can get them to the next level of care, then that's you know, good enough. Like if limited resources and I just have to maybe not use a tourniquet and do a pressure dressing, if that works and you can save resources, like get them out. If I have, you know, one Foley cath and I have 3 patients that need Foleys, like, can we use a Foley and then clean it and reuse it? Like, there's probably situations and times that might have to be done, but we never trained with limited resources. We never trained to think outside the box. We just, okay, this is a perfect scenario, and if you do these 4 things, the patient will live and nothing ever bad will happen. Well, the exact opposite has happened most of the time. Kind of working here, I've worked with a lot of people who, you know, their sterile field is the half a gallon of iodine poured all over the patient just so they can get their belly open, so they can clamp these 2 arteries so they stop bleeding out in their pelvis. Like, oh, you don't have to do all this crazy like draping. It's like, nope, you just need to get in there and stop the bleed. We'll worry about it later. Like, oh, I don't have to do this like really cool, you know, cut down kit, or I have this great crite kit. It's like, nope, just make a hole and put something in there air can pass out of. An ET tube is fine, or whatever you have. Like, you know, we don't do that high level of training, or really any training. And it kind of goes back to, you know, all of the things I was kind of bringing up is like the future of a soft medic or a future of an 18 Delta. You know, I think everybody understands like we're probably going to start going towards a near peer environment. Limited medevac, no more golden hour unless we have a ghost team. We have to push patients back through, you know, ground transportation because we don't have helicopters. You know, going into prolonged field care or prolonged casualty care, and like what treatments can you do or what can't you do? I know they're like, oh, you know, an 18 Delta can hold a patient for 72 hours. Like, that's just a made up number. Like, that's not, like, how do you know? Like, a patient that's shot through the liver is not the same as a patient that has a below the knee amputation. So they just say words and like expect us to be able to do it, but like how, what treatments, who does them, where do they do them? There's not enough guidance, not enough ideas of like what that even means. You know, 12 plus hours until there's a medevac. You know, what if it changes where there is no air medevac and I'm driving 12 hours? How many times do we train driving around in a vehicle for 4 hours treating a patient and trying not to get car sick and trying to get an IV or trying to do all these treatments while I'm trying to get my patient to an evacuation point? Not having control of your patient for hours at a time. You know, it's something that, you know, I don't know anybody who's trained for that, but what happens if you are in a you know, prolonged field care, prolonged casualty care event, and you get your patient stabilized, and now they have to ground move them to a different location. And during that movement time, you're using local national assets, but there's no medic on it. You know, are we training enough to set up this transportation and set up the treatments? You know, does this patient has to leave for 2 hours? Can I send a bag of drugs and set a drip rate and hope no one touches it? And I've done enough calculations, enough math to know, like, okay, this 500 and a 500 bag with a 10 drip set will last me 2 hours and 17 minutes. And if the ride's only 90 minutes, then it's enough drugs to get them there. Should we be doing IM bolus of drugs? Like, okay, if I give them this much drug, I should keep them pain free. Should we be sending them with a little bit of drugs and doing some type of regional anesthesia or blocks? We don't talk about it. We don't train for it. Taking down tourniquets. We don't practice a lot. We do that a lot in the course now, but I put a tourniquet on a patient. How long can I leave the tourniquet on? What's my takedown procedure? What am I actually looking for? Is it just as simple as I just put some Hemcon gauze in a hole and wrap it up super tight, and then it's tourniquet comes down and it's all good, but what if that's not the actual case? What if it's multiple holes and I can't take the tourniquet down? Because if I do it, I'm going to lose, everything I have, or I have to keep the patient alive. So I leave the tourniquet on for 4 or 5 hours. And once the tourniquet comes down, then I have to deal with all those repercussions. And we see this a lot in the course. Not having the right equipment, not having the tools, not having the understanding, and like, oh yeah, I would have done this, or I should have done that. Like, well, you're expected to do that now. You are a blue name on a con-op, and like, oh, I've never actually trained on this, or I've been a medic for 5 years and no one's ever supported me, or I've never had an ability to do any of this cool other training. It's one of the things I hear a lot too is like, oh, I can't go to this training because like my team's going to do whatever. And like, believe me, there's enough medics out there that can cover a range or cover the first half of a J set or can cover whatever to get you that extra training. So you kind of help yourself get better trained so you can also help your team. So I guess overall the biggest takeaways and it's kind of the, okay, what are you talking about? Is I can pretty sum it up to like four good points that kind of I've seen over the past couple of years. Medics don't take responsibility for their training. They don't push this with their team, with their battalion, or with their group. And not only the training, but medics don't take enough responsibility. And not all of them, I want to make sure there's a lot of them that do this and there's some that don't. We talk about, day one of the course, and I say stuff like TMEPs or CPGs, and I get blank stares. And like, what is this? And it's like, you don't know what the TMEPs is or the CPGs. Like, where do you get your medical, guidance from? Like up to date, or my battalion tells me I have to do this. And it's not like, oh yeah, I came here prepared to do this training and I know what the TMEP says or the CPG or the Ranger Medic Handbook or the Soft Medic Handbook. Like, I know what it says, so I'm ready to argue my point one way or the other. Like, our instructors are well enough trained to know, like, if you're doing one or the other. Like, we completely get it. Some of them say different things or different drugs. Like, if you're like, hey, I did it because it says it in this book and I feel comfortable doing that based off what my battalion says I can do. Like, we got you, man. Like, I'm not worried about that. But not IDing the patient doesn't have a radio pulse and withholding blood for 42 minutes. That's in no book at all. Battalions and groups need to take ownership of training their medics and giving them realistic training and evaluations and give them fair AARs. Like, I don't understand why we're kind of afraid to give fair AARs and tell people, like, you shouldn't be a medic. Like, it's okay. Like, it's not okay. Like, if you're a medic, you should be a medic, but some people just aren't that good, and we don't want them out there treating casualties and giving us stuff, information over the radio and doing the wrong thing. Like, they just say, oh, okay, well, they're 18 deltas, they're good enough, so get out there. And everybody's seen them, and everybody's been part of that training event or has been to one of the skill sustainment courses. We look around the room and you're like, this person should not be a medic. And why aren't the battalions and groups or even the B teams taking responsibility for what level of training those medics get and how well they can do their job? we don't do enough medical training, and it should be included in every training aspect. It doesn't really matter. There's not a time where you can't tell somebody, we'll use a MAROPS team, like, hey, you're going to do this 3K swim, and why can't the medic just go to one of the guys or somebody set it up so that patient has an injury? It could just be hypothermia. Like, just treat hypothermia. You would be shocked that the inability for some people not to be able to do that. Like, I just swam for 3 kilometers and the temperature of the water is super cold and I am wet and cold, and, treat that one thing. Like, oh yeah, I know what you want to have, but treat that one thing based on what you actually have. Did you just complete a 3K swim with an aid bag or some type of like warmer, or solve the problems? And then having an honest assessment of your capabilities and other capabilities or other people's capabilities. Like, what can I do and not do? Where do I feel comfortable with? What are the things that I am nervous about? Every class we get 1 or 2 guys who are like, oh, thank God I didn't get the burn one. Oh, I was really nervous about that. Like, why? Like, you're expected to do that. Like, oh, I'm so glad I didn't get the pelvis one. I was really worried about, that one. Like, why? Like, oh, I'd never work on it. Like, well, that's A, your fault for never working on it, and B, like, IDing what makes you weak and doing something about it. Like, oh, we're in session right now, and the guy, literally told me, like, oh, I'm so glad I didn't get that crush scenario. I have no idea what to do. And you're like, you're an 18 Delta with like 8 years on a team, and you're telling me you don't know? And he was right, because I set it up again for him to go, because he had verbalized to me, he didn't know what was going on. And he was right, absolutely right. He had no idea what to do for that patient. We look at TBIs and, ICP, and people are like, oh, I just don't know what to do. And it's like, there's a book, there's a CPG, there's a TMAPS, there's a lot of resources. Like, it sounds like you didn't take the time to figure out what your training gaps were, to figure out what you're weak in, and then make yourself better. Because there's a great chance that a lot of these injuries don't have to be combat related. Everybody's seen the post on the internet or watched the videos of car accidents, people falling, impaled objects, boat accidents, car gets hit by a truck, pedestrian gets hit by a car, glass pane falls on somebody. Like, none of those are combat related. They're all events that, if you're driving down the road and see, you're expected to treat. Or if somebody in your team gets hurt doing something, maybe not even stupid, they just get hurt, because it happens sometimes. Like, you're expected to treat those things. So just an honest assessment of your capabilities and where you need to get stronger is pretty much the big takeaways. I hope this wasn't completely boring, or at least makes sense. But we can get into more in-depth stuff later on if you want to. But, going through the last 3 years of all the things you've seen and I've seen about what students do constantly, where they fail at, what are the issues. I mean, just some of the mind-blowing stuff we see day to day is just like, you don't even know that your patient lost their pulse 15 minutes ago, and you're still doing dumb stuff. Like, you don't even know what's going on. And I think it's not because they're terrible, because by the time they get out of here, I think they've got through everything, and they've definitely finished out and polished up the weak areas they had. But why didn't they come here trained like that? Why didn't they come here ready? It shouldn't be you come here to get trained on how to be a medic. It's a skill sustainment. Like, you have to come with skills so we can sustain those skills. You can't come and be a student day one and like not understand why tubing works. And like, I know it sounds sarcastic, but it's literally the things we have to deal with all the time. Coming with some like idea of like, oh, I'm going to use a Nalgene bottle and 2 tourniquets to do a junctional. Like, well, did it work? Well, this is what I would do. Like, no, make that 2 tourniquets in the Nalgene bottle stop his pulse. Like, he's not even hurt. Like, do the thing to make him not have a pulse. And it's like, oh, you can't do it? Okay, well then that idea isn't going to work. Like, why are we solving those problems here and not back at the unit? And why aren't enough people taking responsibility for the training of the medics. And again, I blame the medic first, and then I blame the team, and then the battalion, and then the group. But it sounds like to me it's kind of the culture of how everybody thinks and what's important. And I know I said it, and it's funny, but like when I was briefing those guys, I'm like, you'll see medicine before you see having to fill a radio. Like, you'll see medicine before you have to put a door charge on something. Like, I promise you, just how things are going now. And it was really good to have those team sergeants and those sergeant majors come to that thing and be like, oh, they watch students go through lanes and like, oh, wait, this guy's an 18 Delta already? Like, yep, yes, they are. Like, oh, we don't do enough training? No, you don't. Like, battalions should start taking responsibility for their own guys. Like, yes, you should. So I hope the culture changes, and I hope people start doing the things that they need to do to, become better medics and solve problems and get their strengths stronger and their weaknesses stronger, and be prepared to treat casualties outside of the algorithm you learned at the schoolhouse, and be able to save lives on and off the battlefield. So that was the brief. I think I had 30 minutes. Looks like it went over 50, but it's all right. I was going to go a lot faster when we were there. But do you have any questions?
Yeah, I mean, so I guess the first thought is everybody, how do I say it? Kind of advertise ourselves. Other people advertise for us about being alpha males and constantly striving to be better in all aspects of everything that we do. But obviously, that's not really the case, right? Not that anybody else is really any different. I guess, how do you overcome that?
You're saying like our own personalities?
Yeah.
I mean, we have all spent times on teams, and we all see those personalities. And I guess the first thing would have to be is, just take an honest look at yourself and say like, hey, am I this guy? Am I this guy who actually knows what's going on? And am I a good medic, a good Bravo, a good Charlie, a good Echo? Or am I the guy who thinks that they're this good and they're not really? I guess it takes a lot of self-reflection, but at the same time, the people who probably need to do the most self-reflection probably aren't going to do it. What's that saying that goes like, I don't even want to guess. It's something about like, dead people don't know that they're dead. Just the people around them are the ones that are hurt, and stupid people are the same way. Like, stupid people don't know they're stupid, right, but it hurts everyone else staying around them. So, IDing those issues, and IDing, where the problem child are, and IDing what your weaknesses are, than trying to fix them. And it's easier to say than it is to do. I understand that, but again, and this is my brief about me and the mistakes I made. Like, never once, I knew where these information came from, but never once was I was like, you know what? I want to take a ton of my own personal time after I just got back from a JSET, and I'm being told to go to language, to like really sit down and figure out why calcium is so important when I'm giving a unit of blood. It was like, it says it in the book. It's good enough for me. Like, my guys went through TCCC, and we did some extra training. And yeah, they're probably good enough. And then there was times where I was definitely thinking, like, I'm going to die today, and there's no one on my team that can save me if I get completely messed up. Like, so, haha, joking, but please make it an easy death. Like, look at me, what I'm telling you. Like, make my death an easy death. Like, don't mess around with a bunch of other stuff. Like, if I'm going, don't let me die hard. And it was like, should probably have figured their weaknesses out before I went into a combat zone with them. And then it comes down to the team sergeant knowing the strengths and weaknesses of his team. A lot of times we have team sergeants who are super strong and they make their guys do stuff, and sometimes they go too far and the team's hurting because they train or work too hard. Other times we have guys who are just so laid back that so many things are being dropped. So I guess the answer to that is the culture and a mindset.
To be honest, I would love it if the only weaknesses that I was coming into with students was, he didn't understand the mechanism of calcium within the body, or why sodium bicarbonate is used or not used. Usually,
You can't get guys to understand they have to give blood.
right?
Or that
Or
like 100 IM of ketamine, that's the dose, isn't it?
Right.
I'm like, what?
It's really,
No.
I think where things go really sideways is the basics, not knowing the basics very well. Super easy to top off the higher intellectual stuff, but not showing up with the basics, which is something super easy to do even before lunch, is to just do an IV, do a drip calc. These are pretty basic things that
Put a tourniquet on.
Put a tourniquet
We had to
on.
do tourniquet drills last class with
Right.
one of the small groups.
Right.
Like, what do you mean you don't know how to put a tourniquet on? And maybe it ties into the culture of here, of SWIC.
Yeah.
You know, if we lower the standards enough, and if we allow people to get trained at a mediocre level, the basis of what they're getting trained on is mediocre, and I'm not saying it is, but then we lower all the standards and ideas. Then they go on and like, oh no, I just left the premier training facility for medicine in the world, and like I did 6 successful IV sticks. You're like, wait, hold on, say the whole thing over again. You did 6 IV sticks the whole entire time? Oh yeah, we have these badass simulators. Okay. Okay. Well, give me an IV. Okay. You just blew that one. You just messed that one up. You just messed that one up. Like, yep, that 6 you got in the schoolhouse was definitely sufficient for you to do medicine. So yeah, it's hard. It's frustrating. I know people don't believe us, but it's literally the level we see day to day is just mind numbing sometimes. First of all, how are you a medic? Second of all, how have you kept yourself alive for this long? Like, you can't. The things you're saying is mind blowing to me.
I think part of that also goes. You're talking about AARs, and they're pretty lame. Or you get the compliment sandwich, where you're complimenting how confident they walked. Oh yeah, by the way, you forgot to look at the giant hole in his back, but. That aid bag looked really good.
Really good.
And like you put them on a litter.
Yeah.
And you remembered to put the straps on it, so that's extra
that's
good.
That's good.
So, that's all, rounds complete.
Yeah. I have nothing to add either.
Yeah.
Like, what do you mean? You're the second guy to talk. What do you mean you have nothing to add?
It's you have thick skin, and if you don't have thick skin, I personally don't think you belong in the community, but it is what it is. Can't be honest about what you did or did not do, then there's no way for anybody to grow. And that's not just medics or 18 deltas. That's essentially anybody in medicine or anybody with a skill that is critical. If you can't look at yourself or have somebody else up here look at you and be honest about a performance that they saw, there's no way for anybody to grow. So I'm not saying everybody needs to just bash the crap out of each other as a competition, but an honest evaluation of what's happening is necessary for anybody to at least get that wake-up call that maybe you need to practice something.
Like your job.
Yeah, like, your job.
What we are paying you to do. I guess one more thing, too, that I kind of didn't. I didn't put into the brief, but I was just thinking about it is we only really train on military-age males.
Yep.
It's never been a thing that I've ever seen outside of here where it's like, okay, here's a child or an elderly patient, or you have to do this. It's always it's the resources we have here. It's military-age males who are getting moulage, so we're going to treat them as such. But we just see a lot of, the chances that you're going to have to treat a child if we go along to a near-peer event in a foreign country is probably pretty good, I would say. Like, again, there's no one in the world expects the U.S. military not to be the best and to fail. Everybody's like, oh, the Americans are here. We are saved. So here's my sick child. Please keep them alive. And you're like, oh, I
Yeah, well, I mean, Afghanistan, Eastern Afghanistan, the Korangal there, I would say at least a third, if not half of the patients were pediatrics. And they were trauma.
Yeah.
Real deal trauma, not just, a broken arm or something. We definitely had those, but I mean, if you want to see somebody's pucker factor, take all those moulage things that you had and then superimpose that on a child, and you'll see like the most hardened man like crumble.
Oh,
quick.
I'm not ashamed to say this. I've had tears in my eyes treating children before, burn patients, IED patients. I think I've told you the story about we had at the FSD, we had a 6 or 7. I don't really know how old she was, but she was young. And we had her down, the CRNA had her down and we were debriding the burns and she had tears in her eyes, completely sedated. And you're looking at this girl thinking like, this is the best medical care you'll ever get. Like, we have to keep you alive. Like, this is it. Like, you're not going to go. They're going to like wrap you in whatever. And like, this is it. And like, just watching the tears come out of her eyes and just being like, oh my gosh, man. Or, we had, an IED strike in Nangnar. It killed 2 children. One was a baby. And like watching they did great. Like the FST that was with us, they did a fantastic job. They did everything they could to the point where like we had to go in and be like, okay, it's done. Like, you guys have to stop. Like, you're wasting resources. Like, I don't want to be the person to make this call, but like, you guys are now emotionally invested in this. Like, we can't do this anymore. Like, we have more casualties coming in. Like, other people need your help. And like, we don't train on that. We just like, oh, we're just going to treat the guys on my team. And that's the only people I have to ever have to treat. And that sign down there, it says like, I'm not a good medic, but I'm your medic, like really holds true a lot of the times when people always see come through here. Like, yeah, that's actually super accurate. Yeah. Sorry. But yeah. And I think maybe on the slideshow, you'll be able to see more. I added a bunch of pictures in there and there was, a couple of GSWs to kids that I had to treat and a couple other things that we end up having to treat that, you're just not prepared for, and you just hope you do the right thing. And that, like the shirt says, like, hope is not a plan. So maybe we should just get better at our jobs.
Right. Yep. Well, thank you, Nate, for your little presentation.
Yep. Thanks for having me, and I'll come back anytime.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.